Hi guys, my name is Harshit Acharya and today I am going to give you a brief introduction about diabetic ketoacidosis. But before I start with diabetic ketoacidosis, I would like to give a brief on how to prepare in the final year of MBBS. Final year of MBBS, according to me, is the easiest year you can get in the entire course of MBBS. This is because final year is a mere application of what you have already studied in your first and second year. And if your basics are right, then application is always easy. With this knowledge, you can actually read the book without reading it. Meaning, if you apply your concepts on the basic pathology, you can actually predict the clinical features, the laboratory investigation, and the treatment. Let me explain this with the example of diabetic ketoacidosis. Now, what is diabetic ketoacidosis? Diabetic ketoacidosis is basically acidosis that develops in patients having diabetes due to the formation of ketone bodies which are acidic at physiological pH. Now, so that forms the definition of diabetic ketoacidosis. Now, who is prone to developing diabetic ketoacidosis? Is it those individuals having type 1 diabetes or is it those individuals having type 2 diabetes? It's those individuals having type 1 diabetes. Have you wondered why? Let me explain. Type 1 diabetes is characterized by lack of insulin formation due to the destruction of beta cells of the islets of pancreas, which are responsible for insulin production, whereas type 2 diabetes is mainly due to insulin resistance. Hence, you have some activity of insulin despite of there being resistance. It's similar to myasthenia gravis. Okay, there are antibodies towards the acetylcholine receptors, but there is some acetylcholine activity which is particularly more in the morning, and as acetylcholine degrades over the day, it's less in the evening. Similarly, there is resistance towards insulin by insulin receptors, but there is some action of insulin that helps in overcoming or preventing diabetic ketoacidosis. But not that it cannot develop in those with type 2 diabetes. It can, if these patients have due to insulin resistance will have an overload on the pancreas to form more insulin. That will lead to burning out of the islet cells of pancreas, leading to hypoinsulinemia even in these patients. Okay, so type 2 can also have diabetic ketoacidosis, but is more common with type 1. Alright, now let me explain the pathophysiology of diabetic ketoacidosis. So till now, what have we discussed? We have already discussed the definition of diabetic ketoacidosis, which is development of acidosis in a patient with type 1 diabetes due to formation of ketone bodies along with hyperglycemia. And we have discussed as to who is prone to developing diabetic ketoacidosis. It's those patients having type 1 diabetes and also chronic alcoholics. Okay, now let's understand why would patient with type 1 diabetes develop ketoacidosis. Okay, so to understand the basic idea of how to apply your basic science knowledges into a clinical application, let's go stepwise. Okay, so what is type 1 diabetes? Type 1 diabetes is a disorder in which insulin is not produced. If insulin is not produced, there would be an imbalance between the hormone causing hypoglycemia, that's insulin, and between the hormones causing hyperglycemia, that's the stress hormones, which are basically glucagon, epinephrine, cortisol, growth hormone, thyroxine. All of these against insulin. Now, with the most important being glucagon, epinephrine, cortisol. Okay? Now, if the insulin decreases, see, there is some basal level of insulin, there is some basal level of stress hormones. Now, if the insulin decreases, the basal level of stress hormones is higher compared to the basal level of insulin. That leads to an overall increase in the effects of these stress hormones. Okay, so now let's understand the basic pathophysiology behind this. Okay, so there's this patient with type 1 diabetes. He does not have insulin production. If he does not have insulin production, there would be a decreased expression of GLUT4 or glucose transporter 4 in the adipocytes and skeletal muscle. If there's decreased expression of glucose transporter 4 on the adipocytes and skeletal muscle, there's decreased uptake of glucose by these cells. And if there's decreased uptake of glucose by these cells, obviously there would be hyperglycemia. Okay? Now, as we said, there is an overall imbalance and the increase in the amount of stress hormones. Okay? So the stress hormone, especially epinephrine, would stimulate the hormone sensitive lipase in your adipocytes. This stimulation of hormone sensitive lipase in your adipocytes would cause breakdown of triglycerides that are stored in your adipocytes. These triglycerides are broken down to fatty acid and glycerol. Now these fatty acids and glycerol are then mobilized to your liver. But as I said, friends, the liver is now in the glucagon world. Why? Because of an overall increase in the level of glucagon, along with which you have to understand this. The beta cells of the islets of pancreas are actually located in the center of the islet cell mass in the pancreas. So this is the beta cell in the center, and surrounding are the alpha cells and the delta cells. The alpha cells secrete glucagon and the delta cells release somatostatin. Okay? So once the arterial blood first reaches the beta cell, stimulates the insulin release. This insulin would then travel towards the periphery, inhibiting glucagon release. Now, if insulin is not released, overall that inhibition on glucagon release is also decreased, and you have an increased level of glucagon. Now, this glucagon would act on the liver. Okay, in the liver, it stimulates the enzyme. It inhibits the enzyme acetyl-CoA carboxylase. And once you inhibit the enzyme acetyl-CoA carboxylase, it does not form malonyl-CoA. Okay, and malonyl-CoA is responsible for inhibiting the enzyme responsible or very important in beta oxidation. So if you don't have malonyl-CoA, you have a decreased inhibition of the enzymes leading to beta oxidation. And if there is a decrease in the enzymes leading to beta oxidation, there would be an increased beta oxidation or increased degradation of fatty acid. This is what happens in the liver, my friends. As this fatty acids enter the liver, they are transported to the mitochondria, where the fatty acids are broken down into acetyl-CoA. Because as we know, fatty acids are a cluster of acetyl-CoAs, and with beta oxidation you just break it down to acetyl-CoA. And these acetyl-CoA then enter the electron transport chain to generate ATP. But liver already has enough ATP through glycolysis, because it is getting its glucose supply to GLUT4. Okay, but liver mainly utilizes fatty acids, so it would utilize these fatty acids to generate ATP. But once ATP is generated, it would inhibit the Krebs cycle. So this leads to an accumulation of acetyl-CoA, and this acetyl-CoA is then converted into ketone bodies. This leads to an overall increase in the level of ketone bodies in your body. So with this basic application of biochemistry, you do understand the pathophysiology of diabetic ketoacidosis. Basically, it's a combination of hyperglycemia along with an increased ketone bodies which lead to acidosis. So you can actually form a triangle, which are the basic hallmarks of diabetic ketoacidosis. That's hyperglycemia, acidosis, and increased ketone bodies. Simple. Now these ketone bodies enter your blood at physiological pH. They behave acidic, leading to diabetic ketoacidosis. So that's the basic pathophysiology of diabetic ketoacidosis, and you can simply depict it in the form of a flowchart in your paper within 1 to 2 minutes. But this flowchart would be really very important in impressing the examiner. He would know that you have understood the disease right from its core. Okay? And now you don't need to memorize the signs and symptoms, my friend. You would just get it all right. Let me explain how. Okay? Now, let's take three the three aspects of the triangle that we formed one by one. Hyperglycemia. What does hyperglycemia do to your blood osmolarity? Hyperglycemia is basically an increased glucose, and this increased glucose would increase the amount of solutes in your body. And if you increase the amount of solutes, what does it result in? Hypotonic or hypertonic solution? Obviously, it results in a hypertonic solution. And hypertonic solution would attract more water towards it. Okay, so your ICF would basically transfer to your ECF and your vascular volume. But that's not important. Because of this hyperglycemia, you overgo the renal threshold of glucose. Because you overgo the renal threshold, your glomerulus now starts filtering glucose. And if you start filtering glucose, the osmolarity of your nephron tubule increases. And if the osmolarity increases, as I told you, if the solutes increase, it would pull more solvent to balance the osmolarity. That would result in pulling of more water into the renal tubules or the lumen of the nephron, resulting in increased formation of urine. And that urine would obviously be dilute, containing high amount of glucose and high amount of water. Okay, and that leads to an increased urine output or polyuria. So do you understand how does diabetic ketoacidosis lead to polyuria? Do you really think you need to memorize anything in this? No, it's just a basic application of your basic sciences. Okay, so that leads to polyuria. If you're urinating more, that is, if you're excreting large amounts of water in your urine, what would that lead to? Dehydration, correct, or hypovolemia. And if you have hypovolemia, what will happen to your blood pressure? Your blood pressure would decrease. But initially, that decrease in blood pressure would be precipitated as postural hypotension, as when you get up, there is peripheral pulling of blood into your lower limbs that decreases the venous return to your heart and subsequently your cardiac output, leading to hypotension. So initially, it's presented as postural hypotension. Later on, as you start as you excrete more and more water, that leads to frank hypotension. So it's basically polyuria, dehydration, hypotension due to hyperglycemia. Okay? Now, let's take the other aspect of the triangle, acidosis. Okay? Acidosis. Or rather than acidosis, let's first take ketone bodies. Or let's just take them together bits because it's ketoacidosis. So ketone bodies lead to acidosis. Because you have large amount of ketone bodies in your body, it leads to a fruity smell of your breath. Okay? And this ketone bodies along with acidosis would stimulate your brain, leading to Kussmaul's breathing. Kussmaul's breathing is deep and rapid breathing like this. So your patient would have a fruity smell, he would have Kussmaul's breathing, he would have polyuria, dehydration, hypotension. Okay, but what is the first symptom of diabetic ketoacidosis? It's abdominal pain, nausea, and vomiting. Okay, it's basically abdominal pain, nausea, and vomiting. That's the first symptom of diabetic ketoacidosis, which you got to remember. Okay, so now I'm in this clinical scenario. I get this patient. I see the classical signs, that's dehydration, polyuria, hypotension, Kussmaul's breathing, fruity smell, abdominal pain. I see all of these signs. Okay, I ask the relative, hey friend, does this patient have diabetes? There are two aspects. Either he would know, yeah, he would tell you yeah, he has diabetes, and then you would ask him since when. He says since childhood, and you're probably thinking, okay, it's type 1 diabetes, and this is ketoacidosis. Second, he doesn't know anything. What would you do next? You would immediately take the blood sample. You would measure the blood glucose. Your blood glucose would be explicitly high. Okay, so now you have a suspicion, yeah, this is diabetic ketoacidosis. Take another blood sample, send it to the biochemistry department, and get his electrolytes checked. Okay, his electrolytes would definitely have an imbalance. Why? It's because of this excretion. You would have hyponatremia. Why? Because of excretion of more fluid. What do you think would happen to potassium? What do you think would happen to potassium in this case? My friends, potassium can either increase or decrease. Why? Why? Why would potassium either increase or decrease? Let me explain. Insulin is basically important for driving in potassium into your cells. Okay, for driving in potassium into your cells, you actually use insulin in hyperglycemia. Sorry, in hyperkalemia, because it's important in driving in potassium to your cells. Now, since you have a lack of insulin, you would expect an increase in potassium levels. But not to forget, you're having polyuria. You're losing electrolytes in vomit and urine. That can lead to hypoglycemia, along with which you're also losing large amounts of sodium. And you know there's the sodium potassium pump, okay, which is activated by aldosterone in your renal tubules. Obviously, when you have hypovolemia, your blood pressure decreases, your N-angiotensin is going to increase, your aldosterone is going to increase. Your aldosterone, in the process of trying to absorb more sodium, is going to excrete large amount of potassium. That can lead to hypoglycemia. That can lead to hypoglycemia. And the chances of hypoglycemia, my friend, are higher than hyperglycemia. So your patient can have hypoglycemia. Sorry, hypokalemia. I'm sorry. If I've said glycemia in this electrolyte portion, kindly ignore it. It's hypokalemia. Okay? So that's basically your electrolyte abnormalities. Now, what are the laboratory investigations that you would like to do? I've already mentioned blood glucose. Okay? Then I would like to mention, I would like to check the urine for your pH because, I would like to check your urine for your ketone bodies, basically acetoacetic acid and beta hydroxybutyrate. Then I would like to check your serum for electrolytes, sodium, potassium, etc. That's basically it. You have the diagnosis of diabetic ketoacidosis. Now, how would you like to manage it? Okay, how would you like to manage it? Okay, my friends, tell me, what's more important in this case? Should I administer insulin because it's basically that insulin deficiency that has led to all these problems? Or should I first administer IV fluids? It's definitely IV fluids because my patient is having hypotension, which is a life-threatening condition due to loss of fluids, and hence administration of IV fluids is far more important than administration of insulin. Yes, I'm not saying insulin should not be administered, but your first priority is fluid management because hypotension can lead to a decreased blood supply to your brain, and that can be catastrophic. Okay, so you first want to administer IV fluids, and that's a more important line of management than administering insulin. But but I don't mean to say insulin is not important. Insulin is equally important. Okay, so now I have this patient in the ER. I have established the diagnosis of diabetic ketoacidosis, or I even predict that this would be diabetic ketoacidosis. What would I first do? I would first administer IV fluids to it in what bolus or slow IV infusion. Obviously, large boluses. Okay, so I would administer 0.9% NaCl, about 2 to 3 liters in about 1 to 2 hours. I'm sorry, I don't remember the exact dose. Kindly go check it with your book. Okay, once I've administered this gradually, and also along with this, I would administer insulin. Which insulin should I administer? Regular insulin, because that's the only insulin you can give IV, and in this case I want a rapid action. I have to uh, inject that insulin IV, and the only option I have is regular insulin. So I administer zero point 0.1 unit per kg of regular insulin to my patient. But what would I check before administering insulin? There's one thing that I need to check in particular before administering insulin, and that's my plasma potassium level. Why? Because in this case, I'm expecting hypoglycemia. Now, what is the action of insulin on potassium? Insulin transports potassium into the cells, leading to hypoglycemia. So, in a hypoglycemic patient, I'm administering a drug that can lead to further hypoglycemia. Hence, I need to check the potassium levels before I administer insulin. Now, there is this guideline. Okay, normal potassium level is 3.5 to 5.5. If your potassium level is less than 5.5, you administer about some milliequivalents. I'm sorry, I don't remember it. And if it's less than 3.3, then before administering insulin, you have to administer potassium. That's about 40 to 80 milliequivalents of potassium chloride. Okay. So now, gradually, my blood glucose would increase. Might decrease, or improve. Sorry, my blood glucose would decrease and improve. Okay, so it would reach about 250 milligrams per deciliter. Okay, now once it reaches this, I can taper my insulin. But what should I do with the IV fluid? The IV fluid, I would then change it from 0.9% NaCl to a more hypotonic solution to 0.45% NaCl. And why would I do so? This is because if I keep on administering a 0.9% NaCl, it can lead to hypochloremic acidosis. And I don't want that. Hence, I decrease the amount of chloride, I administer 0.45% of insulin. Gradually, the blood glucose would decrease, the fluid level of the patient would increase. I start tapering my dose. Okay, kindly check that table in Harrison for the exact flowchart of the doses, because I have just abruptly started taking this lecture. I'm sorry, I don't remember the doses. Okay, and gradually you can start the patient on a long-acting subcutaneous insulin, because it's basically due to lack of insulin that all these problems have happened. Okay, and administration of a long-acting subcutaneous insulin would really help. Okay, it's basically occurs if the patient has forgot to take his insulin dose, or if he's not taking it on the right time, or if he's taking a short acting insulin, which basically leads to a point where there is lack of insulin in the body. So with this example of diabetic ketoacidosis, we can actually understand how application of basic sciences can lead to formation of medical and surgical answers. And honestly, my friend, trust me, I haven't revised diabetic ketoacidosis before taking up this lecture. It's only through the application of my basic sciences that I have derived everything I have said. I haven't revised it in the past 2 to 3 months after my final year exams got over. So you can imagine, this actually leads to development of concepts and retention of important concepts in your long-term memory. Hence I seriously recommend all of you to follow this protocol of study, because this protocol of study would lead to development of strong concepts, would allow you to think, would allow you to develop more interest in your studies. And if you can read the book before actually reading it, that just pushes your confidence level to a maximum. And even during exams, you don't need to sit in front of the book memorizing everything. You can actually derive everything while revising. You can just say, okay, diabetic ketoacidosis, what's the basic pathology? If this is the basic pathology, what could be the clinical features? If these are the clinical features, what investigation should I do? And if these are the investigations, what treatment can I give? That's it. Even during the exams, you will have a very easy life. And if you're asked something new in the exam, if you have developed your mind, if you have developed your mind in such a way that by imagining the pathology, you can apply your knowledge and derive your clinical features, investigation, and treatment, if something comes up in the exam that you haven't read even once, I'm sure you can write an answer. And this has happened with me. We had papers of medicine and surgery with questions that were never asked before or were asked once in the past 10 years. And obviously, I didn't read them, but I could actually derive the answers from my basic knowledge. So if you start studying in this pattern, it's really going to help you. And if this lecture does help you, kindly tell me. I will give more lectures on topics that I know well, like the tetralogy of fallow and pedia and many other topics, like hemorrhagic diseases in newborn, and some surgical topics like achalasia cardia. There are many topics that I know. So if this lecture does help you, kindly tell me. I would upload more lectures. Thank you very much and hope it helps.